Hello. Today's lesson, we're going to be talking about labor and birth at risk and I've added a few of the selected health conditions and some obstetrical procedures. So let's get started. When we're talking about pregnancy at risk, labor and birth at risk, we're really talking about some of the conditions during pregnancy that can lead to delivery complications. So we've talked about these in some previous videos, and we're going to go a little more in depth into the hypertension in this section. But placenta previa, placenta abruption can lead to delivery complications. Hypertension and gestational diabetes can lead to delivery complications. So it becomes complications for both mother and baby. Other issues that can arise during delivery that will make it complicated would be a cord prolapse, a shoulder dystocia, or any sort of dystocia. That term just means difficult. So if I'm talking about a shoulder dystocia, it means the shoulder is not able to fit through that pelvis. If I'm talking about a labor dystocia, it's where the labor has become difficult or taking longer than it needs to be. We'll talk more about that. Fetal distress, amniotic fluid embolus, often called AFE, and hemorrhage. We will actually spend more time discussing hemorrhage in our postpartum lecture, but we will briefly discuss it here. So this is a slide that I like to bring to everyone's attention. In previous lectures, we've talked about the current environment of labor and birth and maternal mortality and C-section rates in America. And this slide is actually just terrifying. This is looking at the mortality rate in the rest of the world versus the United States. And for specific reasons, this is multifactorial. There's lots of issues that come into this. But if you're looking here at the developed regions, you can see throughout the last 30 years, we've seen a significant decline in maternal mortality. But in the United States, which is this black line, we've seen a significant increase. And like I said, we could spend an entire class just discussing this, but this is a terrifying slide. I've seen it in my own practice. I've seen it in the last 20 years. It used to be unheard of, and unfortunately, I won't say it's commonplace now, but it's definitely more prevalent that we see maternal death. And when we're discussing mortality rate, I've discussed this in a previous lecture, but we're looking at maternal death in that first year around delivery. So during pregnancy and in that first year. These slides are even more disturbing. This is broken down by ethnicity. And this is something that's really being brought to the forefront in a lot of the conferences that I've been attending and a lot of the discussions with AWON and journal articles is we're breaking down our maternal death by race and ethnicity. And our African-American, Black population is dying at sometimes 4 times the rate of our other ethnicities, and we need to figure out what is going on and what is causing this disparity. And here's yet another statistic. Here's the California rate, and here's the United States rate. So United States is again looking at maternal mortality, and we definitely see that we have a rise here. But look at the California rate, and a large portion of this decline in the last 20 years is can be attributed to organizations like the CMQCC, which is the California Morbidity and Mortality Collaboration. I didn't put those letters together right, but I will remember it here in just a minute. But so our CMQCC has doing the research, bringing it out there, putting it out to the partner organizations, AWON doing the research, putting together like the postpartum hemorrhage project and getting that information to the bedside. So this is a true example of evidence-based practice coming to the bedside and affecting change. So when we're looking at the causes of pregnancy-related deaths, this is a nice graphic here, and you can see that the number one cause of pregnancy-related deaths are cardiovascular conditions and cerebrovascular accidents. Non-cardiac medical conditions here, infection here, obstetric hemorrhage, still 11% of our maternal death. Amniotic fluid embolus, this percentage is definitely up. Thrombolytic or other embolisms here, hypertensive disorders here, anesthetic complications, that's one that we don't talk about very much, and then we have our unknown causes. So again, these are trying to break down the reasons for our increased risk of death or surrounding our moms and babies. So I'm going to move into the hypertensive disorders of pregnancy, and I have it listed here, and it almost looks like it's a continuum. It doesn't necessarily, isn't necessarily that way. So over the last 20 years or so, we've seen a lot of work done in this area: gestational hypertension, preeclampsia. You might have heard that called other things previously. We like to just switch up the names every 10 years or so to make it interesting. This was previously called toxemia, but preeclampsia, and then we had some classifications. We called it mild and severe. We've changed those classifications a little bit. Eclampsia is moving into when we have reached having maternal seizures, then we now are eclamptic. We also have something called chronic hypertension. Chronic hypertension is when you are seeing increased blood pressures before the 20th week of pregnancy. So gestational hypertension is after the 20th week of pregnancy, but not reaching the specific factors for preeclampsia. Preeclampsia is directly related to the placenta. So as long as the placenta is still inside the mother, our preeclampsia is going to get worse, and we need to that placenta has to come off the wall of the uterus. So that means the birth has to happen in order for this mom to start getting better. And I'll talk more about these individually. And then, like I said, we have chronic hypertension before the 20th week of pregnancy, and then chronic hypertension with superimposed preeclampsia, where you have a person that has hypertension before she got pregnant, and now she also has preeclampsia. So we're going to move into each of these and discuss them. So looking at preeclampsia, this is the spectrum that is involved there. And again, here we go, California Maternity Quality Care Collaborative, CMQCC. There's our words. So there's lots of things that are surrounding this disease process. They're still learning more about this disease process. We know there has been some specific things that we're looking for. In fact, if you go back to the pregnancy lecture and we talk about the warning signs in pregnancy, just about half of them are relating to diagnosing preeclampsia early. And I'm going to go through the signs and symptoms that we'll be looking for. So the risk factors for developing preeclampsia, we don't exactly know what causes it. So the cause is unknown, but there are some risk factors we know that can increase your chance of developing preeclampsia. Being a prima gravida or primi or primip. This is a first-time pregnancy. That is a risk factor for developing preeclampsia. If the fetus has chromosome abnormalities or some sort of congenital anomalies, that is a risk factor. Multiple gestations are a risk factor. History of preeclampsia in the patient or in the family, especially if it's a first-line relative like a mother or a sister or a grandmother. Chronic stress is a risk factor. Extreme ages, less than 20, greater than 35. Use of ovulation drugs, which we do see more of that. That is more commonplace. History of diabetes, hypertension, or renal disease. Obesity, this is a significant risk factor for developing preeclampsia. And then lower socioeconomic status and poor nutrition also contribute to the potential of developing this disease process. So in the CMQCC toolkit, they discuss, they have a preeclampsia toolkit, and they're looking at when our blood pressures need to be treated. In my career, I've seen the development of these bedside evaluations and specific treatments that have become kind of universal, which is evidence-based practice coming directly to the bedside. So back in that slide that talked about where a lot of our maternal deaths are happening, it talked about cardiovascular incidences and our embolus and our CVAs. And so if we are having blood pressures that are meeting these parameters, then we are at higher risk for those conditions. So any systolic blood pressure over 160 or a diastolic over 110, we want to repeat the blood pressure within 15 minutes. And if it sustains, then we're going to treat within 60 minutes. And here you can use these as alternative triggers. Again, it's going to be based on your policy. And where do hospital policies come from? They come from the nursing staff. So there'll be people within the unit that will be going to the conferences, looking at this evidence-based practice, researching this information in their textbooks, the most current stuff out there, and developing hospital policies in conjunction with providers and other people that sit on those teams, risk management, that sort of thing, and developing the hospital policies. And that's what we as the bedside nurse are beholden to. It is our responsibility to know what the current policy is and to follow the recommendations within the policy for each individual organization. That's something you'll learn when you get out on the floor. So again, hypertension and pre-eclampsia symptoms. Chronic hypertension, this is the blood pressure is identified as being greater than 140 systolic or greater than 90 diastolic, either predating conception or before the 20th week. And then it persists after 12 weeks postpartum. So the use of antihypertensive medications before pregnancy, any of these criteria, we're going to call that chronic hypertension. That means she was hypertensive before she became pregnant. I'm going to skip down here to gestational hypertension. And again, a diastolic of 140 and a systolic of 140, diastolic of over 90 with proteinuria occurring after 20 weeks gestation. This is how we are determining that now we have moved into gestational hypertension. It may evolve into preeclampsia, and we'll discuss that in just a minute here. And then preeclampsia is occurring after the 20th week of pregnancy. Again, we're looking at our systolic blood pressure greater than 140 and diastolic greater than 90. So those parameters are what we're really looking for when we are always doing our assessments. If we're seeing parameters above that, we are always thinking possible preeclampsia, possible preeclampsia. And then proteinuria of more than 0.3 grams of protein or higher on a 24-hour urine specimen, or 1+ on a dipstick, or your protein creatinine ratio of greater than 0.3 milligrams per deciliter. So there's several different ways that we can determine this. If we have increasing proteinuria, then we're going to say that we're moving into preeclampsia, and we would be looking at other lab values, and I'll discuss more of that in just a minute. Eclampsia is the presence of a new onset grand mal seizure while pregnant and with preeclampsia. Sorry, I scrolled there. And or new onset seizures 48 to 72 hours postpartum. It's unlikely that eclampsia is the reason for a seizure past that 7-day mark. We can actually see it. Oh, I'm sorry. I said that wrong. We actually can see seizures up to 2 weeks in our postpartum moms. And so if we have a new onset seizure, grand mal seizure after pregnancy, even though the placenta has come off the wall of the uterus, it takes some time for that body to start to react and start to clear that preeclampsia symptoms. And so if we have a new onset of seizures, most likely it is from undiagnosed preeclampsia, and we need to treat it as such. So those of you working in the ER, this is super important to understand. If a woman's had a baby in the last 2 weeks and she comes in with seizures, we need to be thinking preeclampsia. And the way we treat preeclampsia is completely different than the way you're going to treat new onset seizures of a person that has not had had a baby recently in the ER. So this is why it's important to lay down a foundation, because even if you never plan on seeing a pregnant woman again after this course, you will see pregnant women again, no matter what area of nursing you go into. And these types of things need to be treated appropriately. Oh, I need to go back. I'm sorry. Superimposed preeclampsia or eclampsia on chronic hypertension. So this is a woman that has a new onset of hypertension prior to 20 weeks and a sudden increase in proteinuria, especially if it's already present, a sudden increase in that BP. She might be developing something called HELP syndrome. We'll talk about that in a minute. And the development of a headache or epigastric pain, symptoms that are increasingly moving towards looking like there's some swelling going on, and we can move into eclampsia much faster if we have superimposed preeclampsia on chronic hypertension. So basically what all of these disease processes are is the body is reacting with inflammation, and it's to the pregnancy, to the placenta. We don't know exactly why, but we see the signs of that inflammation. And one of the things is this headache that happens. And women that are complaining of headache, visual disturbances, seeing spots, feeling like their peripheral vision is going away, those are all signs of increased intracranial pressure. And that's from this inflammation that's happening within the body. So these are very ominous signs. She's going to be seizing shortly if we don't get that taken care of. And we will discuss some of the nursing interventions and medications that we use for this condition. So other symptoms, severe preeclampsia, and this is the second half of this page, and I have taken it straight from an ACOG practice bulletin number 33. So if one or more of the criteria are present, we call it severe preeclampsia. If they have a blood pressure of 160 systolic or 110 diastolic or over on more than 2 occasions, at least 6 hours apart. If they have decreased urine, less than 500 mLs in 24 hours, they start having those visual disturbances or headaches that doesn't go away with Tylenol. They start to have pulmonary edema or any sort of cyanosis, epigastric or right upper quadrant pain. This is related to their liver. Their liver is reacting to the inflammation. They will start to have impaired liver function. Their liver enzymes will be off. They might have thrombocytopenia and they'll have renal insufficiency. So we call it severe preeclampsia if they are meeting one or more of the following criteria. And then we can also move into something called HELP syndrome. And this is kind of a continuation of severe preeclampsia. And it's an acronym. It stands for hemolysis, elevated liver enzymes, and low platelet. So HELLP, HELP syndrome. This is when it's just what it says. We start to see that breakdown of red blood cells, hemolysis, elevated liver enzymes, and low platelet. And this is a condition that as it continues, this woman will become sicker and sicker. And eventually, if HELP is untreated, if the preeclampsia is untreated, she can move into DIC, disseminated intravascular coagulation. And then after DIC, she can move into multi-system organ failure. And after that, we see death. So this is definitely, we need to intervene. And what we'll normally notice very quickly is that platelet count. So we're watching platelets very closely on anyone with preeclampsia to try to catch these symptoms early. So I want to talk just a minute about how to obtain a correct blood pressure. I know this was a first semester skill. If you were CNAs or MAs before you came to nursing school, of course you're thinking, I know how to obtain a blood pressure, but I actually attended an entire hour course on how to obtain a correct blood pressure. And I see very frequently many mistakes being made. So the first thing is you want to make sure that you have the correct size cuff, the width of the bladder, 40% of the circumference, and it encircles the arm 80%. So it is super important that we are using the correct sized cuff for that individual patient. We want her sitting or in a semi-reclining position. We want them to sit quietly for at least 5 minutes before we measure them. Bare that arm. We don't do it over any restrictive clothing. The feet should be flat, they should not be dangling, and her legs should be uncrossed. So think about the last time you did a blood pressure, were you thinking about all these things? Has she recently consumed caffeine or nicotine? This is super important because it will affect those blood pressure measurements. And then here we're going to take the measurement, instruct the patient not to talk while you're doing the measurement. And you can take at least one additional reading within 15 minutes. You're going to use the highest reading. Now, there were some instructions before. We used to say, turn the patient to her left side, let her lie down. But now, by doing that, we actually could be masking what's going on with that patient. So we do not change her position unless she wasn't in the correct position to begin with. We want to document the blood pressure, the patient position, and which arm it was taken in. And it's very important that we're using the correct cuff. And if it's an extremely obese woman, sometimes it's hard to find an appropriate size cuff. The cuffs that we have, the larger diameter, doesn't necessarily fit every woman's arm. So if we cannot get that cuff to appropriately fit the upper arm, you can use the cuff on the forearm, and you will use it around the wrist, but it's not as reliable. The accuracy is not as reliable, but it can be used. Looking for other signs. When we're doing our assessment, we're going to be looking for edema. And I put these pictures here just to give you, again, a visual of what we're actually checking for when we're looking for edema. So here, when we say mild edema, this indentation just is about 2 millimeters to just barely indentation, just a little bit. Mild edema is normal in pregnancy. Pregnant women will have some third spacing, especially if they're on their feet, and you'll see it in their lower extremities. As we move into a deeper indentation here, 2+ and more is not normal, and that is a sign of edema. And if she has edema on the outside, she's going to have edema on the inside too. Here you can see she has pitting edema. This is compression socks that she was wearing, and then this is actually the same person before the edema, and then obviously after the edema. So assessing for edema is very important. Doing reflexes. There are some really great videos on YouTube you can access to know how to do appropriate reflexes. This is showing you using a reflex hammer. You can actually use the edge of your stethoscope if you have that rubber around the bell of the stethoscope, but knowing how to do appropriate reflexes are very important, and we will be practicing this when we do our clinic orientation. But here's our patella reflex, and then here we have our reflex in our arm. Looking at that urine, again, we are able to tell so much about what's going on with that patient by looking at the urine. So some facilities still are using dipsticks. Many times we collect the UA, it has to be collected appropriately. She needs to use a little peri wipe, wipe front to back, urinate a little bit into the toilet, and then collect the clean catch specimen. It needs to go directly to the lab. It can't sit around. So within 20 minutes, it needs to be in the lab. And if you're still using these dipsticks, you need to wait a full 2 minutes in order to know if these are going to change color. So you can dip it and then just leave it across the top and let it sit there for a full 2 minutes. Here is the calculation to do a creatinine ratio. There are calculators online. This one is an easy one. I think there's another one on perinatology.com. But in order to correctly calculate your urine protein creatinine ratio, this is the calculation that you would use. And this is evidence-based practice. When we're looking at that ratio, again, we want it to be less than 0.03. When we're talking to any woman about pregnancy warning signs, we need to be discussing these education materials. These are actually available online. Many of the facilities are using these. Every woman needs this information. This is a kind of a very simplified, what is it? what are the risks, what are the signs and symptoms, and what should you do. And so you can see again, stomach pain, feeling nauseous, throwing up, swelling in your hands and face, gaining more than 5 pounds in a week, seeing spots, headaches. These are all signs of preeclampsia. And whether she's had a history of it or not, every pregnant woman needs to be looked at if she's having these signs. Not waiting for the next doctor's appointment, but going into an urgent care, a physician's office, or a hospital to have this looked at. The other education that needs to happen is after they have been diagnosed with preeclampsia, they need to be seen much sooner in their postpartum period than a woman that has not had this condition. So we want to see them within 7 days, regardless of the type of delivery they've had. And this information needs to be given to them in their discharge education material. Here's an early recognition tool. This is normal, this is worrisome, and these are severe. So when we are looking at our assessment, and we're always worried about preeclampsia with our women, we are going to look at these this criteria, and I'll let you take a look at it here. Again, it's got your specific signs and symptoms and the assessment criteria that we are looking for. And some places you're going to see maybe a little bit different value. So this says you want more than greater than 50, and then worrisome is 30 to 49. Remember, we saw earlier in the slide, less than 30 is something to be concerned about. So every source is going to give you just a little bit different reference range. I would never test you on something so minute, and NCLEX usually gives you very broad reference ranges, so you don't have to worry about having a little bit different information from different sources. And a lot of what I have actually put into this lecture is not in your textbook. It is coming from some of the most recent information that's out there, a lot of it coming from CMQCC and A1. These are clinical signs, again, that you want to look for. I've put them in here just so that you would have them, because you don't have these again in your book. And trying to build a knowledge base for you to be able to take care of these women in whatever area you end up in. And then if we are in our worrisome, some of our potential interventions may be considering some of our medications. We're going to discuss that in another slide, but as we are starting to be worried, we don't want to wait until we're in the severe to start treating these women. We want to start treating them early and hopefully decrease some of the morbidity that we are seeing with these conditions. So our management, when we have preeclampsia, one of the things is bed rest. And if the woman is still at home and she has preeclampsia, bed rest needs to be described to her as in bed or on the couch, get up to the bathroom, back to bed on the couch. It's not going to a party and sitting in a chair or chasing your other children around the house. Bed rest is truly bed rest. And we've seen women that have preeclampsia that aren't managing it well at home. We bring them into the hospital, we put them in bed, and suddenly, magically, their symptoms start to decrease. So bed rest actually really can do wonders. Daily blood pressure monitoring, making sure that they're using an appropriate size cuff. There are many automatic cuffs that they can use, but it needs to be a fairly decent model. You can buy them on Amazon. Those that are in the stores, like in some of the pharmacies, those are not very accurate. They're not calibrated, so we don't recommend using those. And very important that we're doing fetal kit counts. After the 28th week of pregnancy, we need to be looking at our fetal kit counts, because our babies, if they're under stress, if they're not tolerating what's happening in the uterus, the first thing they're going to do is slow down all their large muscle movements. So kit counts are imperative for these women to do. They'll be doing a non-stress test and a biophysical profile at least weekly. And that will be up to the provider, but at least weekly, they will be doing those. If we have preeclampsia with severe features, so severe features would be headache, edema, that increased proteinuria, more than 0.3 for a protein creatinine ratio, then they're going to be hospitalized. And we're going to have a protocol. We'll either be using the labetalol pathway or the hydralazine pathway, depending on the provider's preference. And there are protocols that we will follow to treat those blood pressures if they get outside of range. We're going to be putting them on magnesium sulfate. Magnesium sulfate, initially we start somewhere between a 4 to 6 gram bolus, and that's within the first 30 minutes, and then there'll be somewhere 2 to 3 grams per hour to control. It's a seizure prophylaxis. So the purpose of magnesium sulfate is a seizure prophylaxis in this circumstance, and that's to decrease the swelling. It's a smooth muscle relaxer, and it will decrease the swelling and hopefully prevent our mom from having a seizure. The side effect of magnesium sulfate, because it is a smooth muscle relaxer, is to bring the blood pressure down. So we will see it as a side effect, and a lot of people think that's the reason we use magnesium sulfate, but really it's a seizure prophylaxis. So if you have a whole list of orders and you have to decide which one to start, the first thing you want to do is get that mag going and on board, because we want to prevent the seizure. And then we may see induction with oxytocin or some other medication to get the labor started, in an effort to get this baby out and get the placenta out and get this mom on the road to recovery. Now, sometimes women that with preeclampsia with severe features, their bodies go into labor naturally, even preterm. And typically those labors go pretty quickly. It's like the body knows this needs to happen. If we move into eclampsia, then of course we need seizure management. If we are preeclamptic and we're thinking about magnesium, we need to have the forethought as a nurse to set our room up and be ready for that seizure if it does happen. So that means we need to have oxygen and suction checked and ready at the mother's bedside. We need to pad those side rails. We need to have some sort of tox box or group of medications that we would utilize if that seizure happens. Sometimes they let you have those out of the Omnicell early, sometimes they do not. Anytime we are using magnesium sulfate, we need to think about magnesium sulfate overdose or toxicity. And some of the signs of that is decreased respiration, because it is a smooth muscle relaxer, and women can even go into respiratory distress. So we have an antidote to magnesium sulfate, which is calcium gluconate, and that needs to be at the bedside if magnesium sulfate is being utilized. So our nursing assessments are going to change quite a bit once we have a patient on magnesium sulfate. She's now moved from a normal laboring patient to a high-risk ICU status patient that needs very significant monitoring. Again, if we're in eclampsia, a prudent nurse will already have her room set up to manage that seizure, and we may have antihypertensive agents if we haven't already started those, and birth needs to be imminent. So that would be through a cesarean section as soon as we get the seizures controlled. We can't wait now and allow her to have a vaginal delivery. So here's our nursing assessments. If we have preeclampsia without severe features, used to be called mild, not called mild anymore, here are how we're going to do our assessments. And it is going to be per facility, but so all of our facilities will have their own protocol, but this is the recommendation based on the evidence. So here's our antepartum. This is while before she's in labor. Interpartum is during labor, and postpartum is after she's delivered. So these are without severe features if she is preeclamptic. Now, these are for patients that are not on magnesium sulfate. Once you are on magnesium sulfate, we are going to increase those nursing assessments. So here are triggers that should be reported either by the patient to a medical provider if they start to happen, or by the nurse if she's hospitalized. If any of these things happen, we need to think that they need to be reported. So increasing blood pressure. If we cannot control it with our medications, or if she's on magnesium sulfate and it continues to increase, that needs to be reported. A new onset headache, or a headache that cannot be controlled with the measures that we're already taking. Any sort of altered level of consciousness, and you may see that as agitation or restlessness or lethargy, hallucinations, confusion, visual disturbances, blurred vision, floaters, blind spots, seeing spots before their eyes. If any of these develop while in the hospital, they need to be reported to the physician immediately. Upper abdominal pain, especially on the right side, urine output less than 95% of what it was, or a new onset of cough. If any of these symptoms develop, tachypnea more than 26 breaths a minute, tachycardia more than 100 beats per minute, any breath sounds that are starting to sound wet or diminished, if they have an eclamptic seizure, or if we have signs and symptoms of magnesium toxicity, which would be decreased respirations or respiratory distress or arrest, then we need to, that's a overhead call. Let's get the Code Blue team, or whatever the term is called in your facility, ABC team, Code Blue team, en route to the room, and of course the provider as well. So here is our severe preeclampsia nursing assessment frequency, and these are women on magnesium sulfate, and these are the recommendations. When they're getting that loading dose, they need to be looked at every 5 minutes. That means you're not leaving the room. And then it can change to every 60 minutes if these criteria are met, and we want continuous O2 SAT monitoring while they're on magnesium. We also need to be looking at hourly, how much intake and output, so strict INO. We need to be looking at lung sounds every 2 hours, and our reflexes every 4 hours. And the reason why we're doing our reflexes is because we will lose our deep tendon reflexes before we lose our drive to breathe. So we want to make sure that A, they're not brisk and she's not at risk for seizing, and B, that they're not absent and at risk for magnesium toxicity. And then if we do have an eclamptic seizure or magnesium sulfate toxicity, these are our assessment criteria that we would use. Here, if we're treating our blood pressures, either on the labetalol path or the hydralazine path, this is how often we're going to be checking our vital signs. And here are the treatments that we can use for our preeclampsia. I'm not going to go through each one of them here. I do want you to spend some time looking at them. This is again coming from the CMQCC toolbox, so not all facilities will be using all of these medications, but this is how to give it, when to give it, loading dose, initial dose, time frame, and some specific side effects and nursing intervention. So you're going to spend a minute looking at this slide. Go ahead and pause the video if you need to take some notes. Okay, so now when we're talking about magnesium sulfate toxicity, I did cover this a little bit already. Your calcium gluconate, again, is the antidote for magnesium toxicity, and it's 1 gram IV over 3 minutes. So it goes in pretty fast. And then here is a little acronym to help you remember. Your blood pressure is going to be markedly decreased. And what happens when mom's blood pressure decreases? Baby's blood pressure also, or heart rate will decrease. Our urine output is going to be decreased. This is why we're watching very closely for that urine output. MAG is cleared through the body through the urine, so you should have copious amounts of urine when a woman is on magnesium sulfate. And suddenly, if she's not putting that out, we're at high risk for toxicity. And part of the preeclampsia condition is that the kidneys aren't working as well. Respiration's less than 12. And your patella reflex is absent. So let's say you have a mom that's on MAG that has an epidural. You're not going to be able to elicit a patellar reflex because she's now numb. We're numbing those nerves. So that's why we have to learn how to do the reflex on the arm as well. Here is a suspected preeclampsia flowchart. I just put this here so that you can see that we do have these algorithms that we follow that help the providers determine what should happen, when delivery should happen. And this is, of course, going to depend on how many weeks gestation she is. This is what it looks like in the room when a prudent nurse has gotten everything ready, what we call seizure precautions. So the side rails are going to be padded. We want as much privacy as possible. We want to keep the lights down in the room. We don't want to have 50 visitors. We turn the TV down. We make a concerted effort not to slam doors or talk very loudly, because all of those things will excite the nervous system and can increase her chance for having a seizure. We check to make sure that the oxygen is, everything is there and functioning. Same with the suction. I go ahead and put the tubing on and put a yonker on and tape it up to the wall so that it's easily accessible if I need it. We want to make sure the bed's in the lowest position, and that any medications that you can have available are at the bedside. We no longer use any sort of bite block or anything to put in the patient's mouth. That's old ideas. So now we are just protect the airway and protect her from being from injuring herself if she is having a grand mal seizure. And here are some symptoms of HELP syndrome. Again, this is information that we can give to the patient. This one is actually meant for a patient. And HELP is hemolysis, elevated liver, low platelet. This is a continuation of the preeclampsia, eclampsia syndrome. And here are some of the side effects, or sorry, signs and symptoms. Again, that headache, nausea, vomiting, because that liver's involved. Abdominal chest tenderness, especially in that upper right side. If a woman comes into the ER complaining of abdominal pain, the last thing we need to do is palpate that liver, because that could be the last thing that happens before it lacerates. So if she's complaining of abdominal pain, do not palpate the liver, especially if she's having other signs and symptoms of preeclampsia. Changes in vision, changes in swelling, any sort of bleeding from anywhere. And then our treatments, again, bed rest, continuous monitoring of mom and baby, magnesium sulfate to prevent those seizures, blood pressure medications. We might be giving corticosteroids for lung development of the fetus, and we might just keep her pregnant long enough for those steroids to work if this is a very early pregnancy, and she may need blood products, so we need to type and screen her. She's a high risk if she comes in HELP syndrome. So every laboring woman is at risk for hypertension, even if she hasn't been diagnosed with it before, dystocia, which is difficult or slow labor or birth, and hemorrhage. So anytime you have a woman that comes in to labor, you need to be thinking about these conditions. These are conditions that every single person that comes in to have a baby is at risk for. Well, we're going to move on to delivery complications and some things that can happen during delivery. This is a nice picture of a baby born inside that amniotic sac. I think I've used this in another lecture, but it's a good example of what that baby looks like on the how it's living on the inside before it's born. See how that cord just gets wrapped in all different kinds of places? It's just amazing. Dystocia, again, definition, slow or difficult labor or birth. And when we're talking about dystocia, we have lots of risk factors that will contribute to that. Epidural analgesia is one of them, or excessive analgesia can slow down our labor and slow down our birth, slow down especially the second stage, the pushing part, where mom is unable to feel what she needs to do. Multiple gestation is a risk factor for dystocia. Having more than one baby in that uterus means that sometimes the uterus doesn't function appropriately. Hydramnios, either poly or oligo, is a risk. Maternal exhaustion, a 3-day induction and then a 12 or 24-hour labor, that can cause anyone to be exhausted, and that puts us at risk for slow or difficult labor or birth. Ineffective maternal pushing, again, that can be from exhaustion, it can be because of the position of the baby, it can be because of excessive epidural. Fetal malposition, the #1 reason for a labor dystocia is fetal malposition. So that OP, we talked about this in a previous video, but that OP position where the baby's head, back of the head is facing towards the back of the mother, or the baby's facing up, sunny side up, that is not the most optimal position for delivery and can increase our chances of having a labor dystocia. Other risk factors include a longer first stage of labor, and a lot of that longer first stage of labor may be because we're inducing her and she is not ready to be in labor. It could be related to maternal positioning and fetal positioning. Nulliparity, never having a baby before and having a short maternal stature, we call that anything under 5 foot is considered a short maternal stature. That puts us at risk for a shoulder dystocia, where the baby's shoulders do not fit through that pelvis. Fetal weight or estimated weight of over 4,000 grams, which is 8.8 pounds, that puts us at a risk for shoulder dystocia. A history of shoulder dystocia makes us wonder if maybe that woman's pelvis is shaped in one of those non-optimal shapes. Remember, gynecoid is how we really would prefer it to be. Abnormal fetal presentation and any fetal anomalies. These also put us at risk for dystocia. Other risk factors that can increase our chance for both types of dystocia is maternal age, over 35 years old. Those bones start to calcify, everything starts to become a little less able to respond to the hormone relaxin that helps that cartilage to have just a little bit of a stretch to it. High caffeine intake actually increases your risk of both labor and labor dystocia. Being obese, gestational age over 41 weeks, chorioamnionitis, which is infection of the chorion and amnion, ineffective uterine contractions, and a high fetal station when the cervix is completely dilated. So if we have these things going on, we are concerned that maybe we have a potential for a slow or difficult labor or birth. So this is the way that we think of what we see, our traditional way of laboring. And I've told you before in other videos that your bed, this very expensive labor bed, is your enemy. We need to get up and out of this bed. How do we avoid labor dystocia and or fetal malpositioning and or shoulder dystocia? We get out of the bed and we labor in the way that nature intended us to do, especially in that early phase. I'm not saying that you can't use some of the pharmacological methods like epidural and whatnot, but the longer you wait, the better off we are. And if you haven't gotten the epidural yet, then you need to be out of bed and helping that baby to get into the most optimal position. Once you get the epidural, it becomes a responsibility of your nurse and your partner to keep you moving, turning, using the tools we know that's going to help this baby. So instead of laboring like this, we should be doing things like this: peanut balls, using that bed in multiple positions, getting up out of the bed, leaning over the edge of the bed, using our birth balls. There's all kinds of ways. And when it comes to the second stage, instead of pushing like this, which is typically called lithotomy, we need to push in that natural position, getting up, using squat bars, being upright, using a birthing chair, using the bed to our full advantage. This is how we get these babies out. If we were to leave a woman untouched and she would labor on her own, she would never get in this position. This position was created for the convenience of the provider, not for the betterment of the mom and the baby. And as a nurse, you will never pull knees apart in the way that this is being depicted. So nursing assessment for potential shoulder dystocia: any weight gain of more than 50 pounds during the pregnancy, a weight of more than 200 pounds before the pregnancy, any diabetes, either gestational or type 1 or type 2, a maternal height less than 5 foot, a post-term pregnancy, more than 41 weeks, a prolonged second stage, she's been pushing for a really long time, or a prolonged first stage. She's had a really long first stage of labor where her cervix took forever, she got stuck at a certain number for a long time. These are all signs that you need to be thinking of potential shoulder dystocia. Oxytocin induction and mid-forceps or vacuum. So if you identify these risks, what are we supposed to do? What steps are taken by the RN? What other risk assessments are done at this point? So let's talk about that for a second. If you've identified that this is a shoulder risk, you need to notify your physician. This patient's a shoulder risk. Put it on your whiteboard in your wherever you keep your patient information. A lot of them have them in break rooms on whiteboards. Make sure that your charge nurse is aware. Make sure that your anesthesiologist is aware. And you're going to have NICU at the bedside and at least 2 RNs that are trained in dealing with shoulder dystocia. You want to have stools available so that you can jump up on that bed. You want to discuss with the mom, you're concerned that this is a potential for a shoulder dystocia, and these are the steps we're going to take to try to prevent it. If once it's identified that it is a shoulder dystocia, the provider will be in the room, and we will very closely listen to what the provider is as far as maneuvers. Now that you've had a shoulder dystocia, what other risk assessments? You want to, once that baby is out, we want to check to make sure that there's no injury to the shoulders. And we'll discuss more of that when we do our newborn video. We want to, now we're at risk for a hemorrhage. So we can go from a shoulder dystocia to a hemorrhage very quickly. So we want to be prepared for those things. So this is the normal position of the shoulders. This is how we would like them to come down through that pelvis. And what happens during a shoulder dystocia is you can see these shoulders get hung up on the edge of this pelvis here, and they aren't able to fit. The head has already come out. It's already all the way out of the vagina, but the shoulders are still stuck behind those behind the mother's pelvis. So some of the maneuvers that we need to do, here's an algorithm, and you can stop the video and look at that. But here, some of the maneuvers that need to happen, some are nurse driven and some are physician or provider driven. So we need to be working very closely as a team. Again, this is just another picture of this is how it should look. That's part of those cardinal movements of birth. And this is what it looks like when the baby comes down through the and is born, and there's a shoulder that has not been able to clear that pelvis. If we can't get this baby out, this baby will die. And we have a very short amount of time to do it. So this is, again, shoulder dystocia. Here's an actual shoulder dystocia in progress. And one of the signs that the shoulder dystocia is happening is the baby's head will come, and then it kind of turtles back in, and the shoulders don't immediately follow. So they call that the turtle sign. And as the baby is born, we want to be watching very closely for the turtle sign. Once the shoulder dystocia happens, they have to be very careful not to just wrench this baby out or put a lot of pressure, because there's a very sensitive nerve here. It's called the brachial plexus nerve complex. And if this is damaged, this baby will have permanent damage to this arm, and in some cases it's not functional. So we want to be very careful not to damage this nerve here. There's also the possibility of umbilical cord entrapment, which means that we're compressing that umbilical cord and the baby is not able to get any blood flow. If that were to continue, there would be severe hypoxia and potential acidosis and brain damage, and then again the brachial plexus damage. So one of the maneuvers that is nurse driven is called the McRoberts Removed maneuver. And this is when, whatever position it is that she has delivered this baby's head, we're now going to help her bring her knees up as far as she can reach them. And by doing that, you see that we change the position of that pelvis just slightly. And that may be enough for these shoulders to slip underneath. Another aspect of this is you can actually put this patient's knees together with the ankles out, and that opens the pelvis rather than closes it. And so that will help as well. Traditionally, and this is one of those spinning babies magical moments, we have always tried to open these knees as far as possible, and that actually causes this to make a smaller surface area rather than a larger. The next potential step that might happen, and again, this would be driven by the provider, because all of these maneuvers need to be working at the same time, is something called suprapubic pressure. And you can see here, the nurse has used a stool to jump up and actually put pressure right above that shoulder to help press it down underneath the mother's pelvic bone. Here's another example. And they're using this fist to put pressure to push this baby's shoulder so that it can slip underneath this bone. Doing this with McRoberts typically will dislodge this baby. Here's that turtle sign that I was talking about. We want to use the acronym Be Calm. We're going to breathe, do not push, lower the head of the bed. This is the actions that we'll take once it's been identified by the provider that there is a shoulder dystocia. Elevate the legs into the McRoberts position. We're going to call for help. This is when we need our other nurses on board, anesthesiologists, maybe another physician if we have to go back to the OR and do abdominal rescue. We will apply suprapubic pressure, which is downward and lateral, trying to help that shoulder release. The provider may enlarge that vaginal opening with an episiotomy to facilitate other maneuvers. And then some of the maneuvers they may do are delivery of the posterior arm, pressure against the posterior shoulder, that's called the Woods, corkscrew, or Rubin maneuver. Moving the mother to the hands and knees position is the Gaskin maneuver, named after Ina May Gaskin, the famous midwife. And then last but not least, our rescue maneuver would be replacement of the baby's head into the vagina and then followed by emergency cesarean. That's called the Zavanelli. Sometimes on NCLEX, they will ask you specific questions about some of these maneuvers. Gaskin maneuver I've seen on there, McRoberts specifically, suprapubic pressure. These are all terms that you need to become familiar with. And so other issues, causes of dystocia, again, remember it's difficult labor or birth, is a hypertonic uterus that causes dysfunction, a hypotonic uterus, so not enough contractions or contractions that are too strong. And sometimes people, in a desperate attempt to try to help themselves go into labor, they will take herbs or even do things such as castor oil. And what they find is sometimes these medications are so strong that they cause hypertonic uterine contractions, which can be detrimental to that baby. Protracted disorders, arrest disorders, precipitous labor. Precipitous labor is labor that happens within 3 hours from start to finish. And even though that sounds like a good idea, everything is happening so fast that baby doesn't really have a lot of time to get into the most optimal position. So we see more shoulder dystocia and more hemorrhage following precipitous labor. And then we have issues with the passageway. If there's a pelvic contraction or any sort of obstruction, tumor in the uterus, sometimes even vaginal warts can cause obstruction in that birth canal. So those can also interfere with the baby coming down and coming out. That occiput posterior position, I've mentioned that quite a bit. Our OP babies, breech presentation, multifetal pregnancy, macrosomia, baby that is large, more than 8 pounds, 8 ounces. CPD, cephalopelvic disproportion, the head is too big to fit through that pelvis. And structural abnormalities, all can cause dystocia. And then psychological stress. A woman that is just fighting every single bit of the labor, maybe is not happy about the pregnancy, has had a history of trauma in her own life. All of those can interfere with labor and delivery. Here's an example of that occiput posterior position. So this is the position we would like the baby to be in, the back of the head facing towards the mother. This is the easiest way for that baby to get down through that birth canal. This is what we call occiput posterior. So the back of the head is facing the posterior, and this is going to cause a lot more back pain, and this angle is not conducive to getting this baby out. So how do we prevent these positions? And this is another example of all the 8 cardinal movements that this baby has to do in order to come out and be born. You don't have to know all of these for my course, but this is just an example. And then this is showing you again the macrosomic child with a very large shoulder girth. You can see why it's much harder for this baby to get out of the birth canal, especially in this position, than this baby. So how do we prevent this fetal malpositioning, occiput posterior positioning? How do we prevent this labor dystocia? The secret is movement. Getting this mom up, moving, being out of the bed, using the bed to the best of her advantage, using all the tools and tricks that we have nowadays is how we prevent it. And as labor nurses, it is our job to educate our mothers this if they do not have this information. This is a very good example of closed knee pushing. And this is some of the spinning babies magic again. So what this is showing you is our closed knee pushing is, if you put both hands underneath your sitting bones right now and open your knees wide, what happens to your sitting bones? Your sitting bones actually go inward. But if you now close those knees, you feel those sit bones go outward. So what you're actually doing is you're changing the outlet of your pelvis. You're changing the diameter of the outlet of your pelvis. So if you have a patient that is struggling to birth her baby, try some closed knee pushing, and here's a very good example of it, and you will quickly see that these babies come through the outlet faster when we use correct maternal positioning. Now we're going to switch gears a little bit and talk a little bit about preterm birth. The definition is uterine contractions with cervical effacement and dilation between 20 weeks and 37 weeks gestation. It's one of the most common obstetric complications, and unfortunately, we still do not know what causes it. It is talked about. There's entire organizations that are dedicated to it. It is discussed at length in conferences. The March of Dimes has been spending a ton of time and money trying to figure it out, and we just don't know why we still have preterm labor and why we still have preterm birth. Risk factors: if they've had a previous preterm delivery, they're at much greater risk for another preterm delivery. There are subtle signs, so we have to be paying very close attention to those contractions. If we see more than 4 contractions in 20 minutes or 8 contractions in an hour, and they're preterm, that needs to be part of the education that they need to come into the hospital and be seen, so we can do some testing to see if they actually are changing that cervix. Now, preterm contractions don't always mean preterm labor because the cervix isn't changing, but we need to treat it as if it does until we determine that it isn't. So there's lots of different testing we can do. We might do a CBC, a UA, looking for infection. That can be a cause. We might do an amniotic fluid analysis, an AFI, to determine if there's been a premature rupture of membranes. We can do a test called a fetal fibronectin, little swab in the vagina that's looking for some specific proteins. And that tells us pretty definitively if that fetal fibronectin is negative, then we will probably not see a birth within the next 2 weeks. So a negative result is what we're looking for. They can do a cervical length via that ultrasound. There are some other tests, salivary estriol, and some home uterine activity monitoring. Some places actually have nurses that remotely watch fetal monitors. We don't have that here locally, but there are some larger cities that do. And all of these are the nursing assessment that we would be looking for preterm labor. If we have determined that she is in preterm labor, we're going to use, there's our old friend magnesium sulfate again, but we're using it for a different reason this time. Magnesium sulfate used to be used to decrease the preterm contractions, because remember, it's a smooth muscle relaxer. But now they know that doesn't really work as well for that purpose, but they did find that magnesium sulfate works very well for neuroprotection in these premature babies. These premature babies have a much higher chance of having a brain bleed if they're born early. And so if we give mom some magnesium sulfate right before she delivers, it can decrease her chance of having a brain bleed. The other medication that we use for preterm contractions is called terbutaline. It's kind of been proven. The research out there really is saying it doesn't do much to prevent preterm labor, but you will still see some providers using it. Terbutaline is only ever given subcutaneously in our facilities anyway. We never do Terb IV because it's been correlated to some very specific pulmonary embolism, that sort of thing. So we only use it sub-Q. So it's a very small dose, 0.25 milligrams sub-Q, and that is repeated once within 20 minutes if the contractions are still happening. There's some little side effects that come along with this medication. It causes the mom to feel like she's been drinking caffeine. It can make her jittery. It can make her shaky. And we need to give her some good education before we use terbutaline. There are no clear first-line drugs to manage preterm labor. Sometimes we use them to prolong pregnancy for a couple of days so that we can get some steroids in to help the baby develop their lungs. And again, by giving mom corticosteroids, we are increasing the surfactant production, which is that soapy substance that's in the alveoli of the baby's lungs, and that helps to mature them on a little bit faster rate. It takes 24 to 48 hours to get full effect. So sometimes we will use medications to keep women pregnant just to get those steroids on board. Antibiotic prophylaxis, especially if she's group B strep positive, and there may be some other more long-term antibiotics if we think that was the reason for the preterm labor to begin with. There are some other infections that can increase that. So our tocolytics, there are several listed here, and this is the mechanism of their action. So I'm going to leave this slide for you there. You can you can pause that video if you'd like and make some notes in your medication reference if you choose to do so. And now we're going to move on to post-term labor. Post-term labor is a pregnancy that continues past the end of 42 weeks. Now, we don't know why some women don't go into labor. The etiology is unknown, but there are some specific risks for a pregnancy that continues past that point. For maternal, that she has a higher risk of having a C-section, a higher risk of having both shoulder dystocia and labor dystocia. There's a higher risk of birth trauma, hemorrhage, and infection. And for babies, there's a higher risk of macrosomia, so being very large, shoulder dystocia, brachial plexus injuries, low APGAR scores, and post-maturity syndrome, and CPD, cephalopelvic disproportion. So these risk factors are increased after the 42nd week. We do see lots of inductions happening much earlier than the 42nd week, and as early as 39 weeks in the current climate. And I will discuss more about induction as we get into our interventions. So this is a baby that has increased meconium production. You can see as this baby was born, he's trying to spit all this meconium out. And this is one of the things that we fear when we have a post-term baby, is that they are more likely to have meconium. And meconium is benign in that it's just the baby's first stool that the baby has released in the uterus. But if it gets into the lungs, it can cause a condition called meconium aspiration syndrome. And if that happens, then we are concerned about breathing difficulties and developing some other lung conditions. So this is just a picture of what that meconium looks like. It can be yellow or it can be very dark, depending on how long it's been in there. Here's some other signs of these these babies that are post-mature. Many of them no longer have that vernix, that white cheesy substance that has been a skin protectant for them. It goes away the older gestation they are, and so you see that they have kind of this peely look to them. All of this will be fine in the few weeks after they are born, but this is a cardinal sign of what a post-term baby looks like. And here's a very good example of the skin for a premature baby. They typically have a lot of hair growth. They don't have creases, all the creases on their foot. This is a quick way of looking at their gestational age. A full-term baby, you can see, has the full creases down the foot, and their skin is not as thin and translucent as the premature baby. And then here you have a baby that's 42 weeks that their skin is very dry and peely, and they have all their creases and they're peeling. So this was just a very good picture of looking at the 3 different gestations. And we will talk more about that in the newborn lecture. So some of the assessment that we will do, our nursing interventions and assessment, is looking at that due date. Was it appropriate? Was it done early on? Again, only early ultrasound is the most effective method for creating an estimate of a due date. And the other thing we need to keep in mind is some babies need more time than others. So we can't just put everybody into this box and expect them to be similar. We're all very different. Daily fetal kit counts are necessary for these women. They need to have good education about the importance of doing kit counts. And if they do not feel their baby move, they need to come to be evaluated. Non-stress tests, usually twice weekly. They'll be looking at their biophysical profile every couple of days, including an amniotic fluid analysis. And then once we do have a post-term pregnancy, really the parents need to be educated about risk, benefit, alternatives. They need to be able to make an informed decision about what they want to happen. We need to support their choices. If they've been given good education, if their provider has given them everything they need to make that informed consent, then we need to support their choices. Here's a little example of how to do a fetal kit count. And I'll leave this here. You can stop the video and read this, and just a little chart of keeping track of it. But being able to give this education to your mom is very important, especially as a triage labor and delivery nurse. Now we're going to move in and talk a little bit about the obstetric emergencies that can happen: umbilical cord prolapse, fetal distress, and amniotic fluid embolus. So when I'm talking about umbilical cord prolapse, this is the partial or total occlusion of a cord, and the baby is not going to be able to tolerate that for long. You and I have about 4 to 5 minutes that we can be without oxygen, and the baby has about the same. So if the nurse discovers this, there needs to be some very rapid intervention in order to try to preserve as much oxygen going to that baby as possible. So prompt recognition and measures to relieve the cord are what your nursing management would be. This is what a cord prolapse would look like. This is a full cord prolapse where you can see the cord is coming all the way out of the vagina, but sometimes it can be a little less pronounced. It will still be up inside. If you are watching your fetal monitor, you will definitely see signs that something's not well with the baby. So watching that fetal monitor can help us to have prompt recognition of this sort of condition. Here are some examples of some other cord prolapses, like I said, that aren't quite as pronounced. All of these could be just as detrimental, because what happens is the weight of the baby is pressed down on this cord, and then if that cord is compressed, we are not getting oxygen to the baby. So some of the risk factors is a baby that is at a high station and has a rupture of membranes, either spontaneously or artificially by the provider, or a baby that is not well engaged into the pelvis, like this baby. There's lots of room for this cord to slip down because of the position of that baby. So if a nurse does discover that there is a cord prolapse, we need to do some immediate response. We will do an exam. We don't try to push the cord back in, but we will try to find the presenting part of the baby and push up to prevent pressure on this baby's cord. And we also want to use gravity to the best of our advantage. So you would see on this picture, if we put mom in a hands and knees position and pushed on the presenting part of the baby, we can take some of the pressure off of that cord. So you'll see this sometimes worded hands and knees, knee, chest. All of those positions, you can just imagine, is helping gravity to pull this baby back down this direction so that we can buy some time until we can get to the operating room and get this baby out. Next, I'm going to talk about amniotic fluid embolism, and this used to be an extremely rare event. And as you saw in that graph that I posted at the beginning of this lecture, it is 4 to 5% of the reason of our maternal mortality rate. So amniotic fluid embolus is the sudden onset of hypotension, hypoxia, or coagulopathy, which is because there has been amniotic fluid that has entered the maternal circulation. The way that happens is still a lot of research is being done. We're not sure why sometimes there is a breach in those two systems where amniotic fluid or fetal tissue moves into the maternal circulatory system. But when it does happen, some women are very predisposed to have an immediate, almost like an anaphylactic response to it. And so the nursing assessment is sudden difficulty breathing, sudden severe hypotension, cyanosis, seizures, tachycardia, coag failure, meaning they go into DIC, pulmonary edema. There'll be uterine atony, so they may be hemorrhaging as well. They go into acute respiratory distress syndrome and cardiac arrest. Sometimes this happens right at the moment of delivery or right after delivery. Sometimes it happens when the mom is still pregnant. And if that's the case, then we have 4 to 5 minutes to get that baby out before we lose both mom and baby. So in the recent years, we've started practicing something called OB-ACLS, Advanced Cardiac Life Support, and we do drills on how to do emergency cesarean sections in the room where the patient has fallen. After a couple of minutes of good quality CPR, if she's not responding, then we need to do what's called a peri-mortem cesarean section in order to attempt to save the baby and relieve some of the stress that's on the mother's circulatory system by keeping that baby alive. A rough concept, unfortunately, it has been used in my geographic area a couple of times in the past few years, and with success. We have been able to save these babies, and unfortunately these mothers did succumb. So this is just a representation of what it might look like and the subsequent circulatory collapse that will happen if an amniotic fluid embolism happens. There aren't a lot of signs that it is going to happen other than that sudden cardiac arrest or those sudden symptoms that mom is exhibiting. Now we're going to completely switch gears and talk about some of the obstetric interventions that we perform. And as labor and delivery nurses, these are all things that we become very well versed in. We will be talking briefly about induction. We will be talking about amniotomy, which is breaking of the water, amnioinfusion, operative vaginal delivery, which includes vacuum and forceps, and cesarean birth. So when a patient has their water broken, a provider, either a nurse midwife or a OBGYN, will break that patient's water. Nurses, bedside nurses, are not, that's not within their scope to do. But this is called an artificial rupture of membranes, or AROM. And there's reasons that they will do it. Sometimes it's so we can do some internal monitoring. Sometimes it's because there is a release of prostaglandins once that water is broken. Sometimes it's to determine if there's been meconium and or if there's infection brewing. Sometimes they will use it to try to encourage labor to continue or to allow that baby to come down. Evidence tells us by breaking that water, we are increasing the speed of labor by about 30 minutes. We also know that it doesn't help with fetal malposition. In fact, sometimes it encourages fetal malposition because that fluid allows the baby to get into the most optimal position. And now we have a potential for infection. So there are lots of cons to rupture of membranes and not a ton of evidence that tells us there's a lot of good benefits to it. So this is something that every woman needs to have a good discussion with her provider and should be able to make a decision whether she wants this done or not. Once the water has broken, whether it be artificial or spontaneously, we need to be looking for signs of infection, and that includes temperature. Depending on your facility, that will be about every 2 hours. And now labor induction and augmentation. So when you're talking about induction, that means stimulating contractions, be either a medical or surgical means. And augmentation is enhancing ineffective contractions after labor has begun. So those two terms are important to understand. Indications for both of these would be prolonged gestation, so our post-term pregnancies, prolonged rupture of membranes, gestational hypertension, cardiac disease and renal disease, infection, chorioamnitis, dystocia, labor that's not moving along as it should, or that is stopped, interuterine fetal demise. So if the baby has died, we do need to induce labor or augment labor that's already happening. Isoimmunization, that's that Rh factor. If we are concerned that there's been a breach and that baby has become affected by some maternal antibodies, we need to induce labor. And diabetes. So those are all medical reasons for inducing labor. What we see is there are lots of social reasons that we want to induce labor. And so I pose the question, just because we can, should we? Now, there's a lot of research that is going on about induction. There's a lot of talk about induction. There was a recent trial that was done within the last couple of years called the ARRIVE trial that a lot of physicians have kind of latched on to. Unfortunately, if you look at the study, it didn't really, the conclusions that it's purporting aren't really there. And some of the study methods weren't what we call very reliable. So evidencebased-birth.com actually has a really good article about the ARRIVE trial specifically. But here's what we know. If we are inducing women that aren't ready to go into labor for reasons that are other than medical, then we are increasing their chance of a cesarean section. That research has been out there tremendously. There's much research about that. So again, I pose the question, just because we can, should we? Every woman needs to know that she's increasing her chance for cesarean section by having an induction. That being said, we have a little predictive way of looking at how likely her induction is going to be successful. And this is by a score that we do on her cervix. And it lets us know how likely she is to have a successful induction. So for instance, anything with a Bishop score of 6 to 8 or more is more likely to be successful. Anything with the Bishop score of less than that is less likely to be successful. So a woman can take this information, you can see that it's a rating system here, and you get points based on these criteria. And every woman being induced should know this number. What is her Bishop score? And then she'll be able to use this as part of her information, as part of her toolbox to make her informed decision. Some of the ways that we can induce a labor is by cervical ripening, so helping that Bishop score to increase by using certain medications. We can use some mechanical methods to get that cervix open, and I'll talk about those in just a minute. There are some pharmacological agents that we can use. We have oxytocin or pitocin, which is the synthetic form of oxytocin. Some women, sexual intercourse, which produces prostaglandins, both in the act of having sex, by having an orgasm, and by having sperm present. Those will all increase the prostaglandins that will work on that cervix. There are some herbal agents out there that have been used for a long time, and then there's castor oil and enemas. The problem with some of these agents that are used outside of the facility is they can cause contractions, and they can cause tetanic or very strong contractions, or too many contractions, and then your baby can be under stress and you wouldn't even know it. So we don't recommend that women use these outside of some sort of medical care or midwifery care. As far as the other medications, there are some medications on the market that we know cause contractions, but aren't specifically meant for that purpose. For instance, we use something called cytotec or misoprostol. That's one of the pharmacological agents. It is an off-market use. It's not one of the reasons that medication was created. It's actually as a gastric ulcer prevention medication, but we know it causes cervical contractions or uterine contractions. So we use it for that purpose. So that's called an off-label use. This is why it's difficult sometimes with meds that are used in labor and delivery, because we don't, the books only are going to talk about the on-label uses, not the off-label uses. And then we have some cervical ripening tools, and I'll move into those. This one is called Cervidil. It's a flat little tampon that has a little tail on it, and it's placed right up here next to the cervix. See how the cervix is very long and thick and not open and posterior? It's towards the back of the woman's body. This Bishop score is not very high. So we would use this as a cervical ripening agent. It's a 12-hour medication. You can have more than one dose. Some women will have very good response to it. Some women have no response to it. There is such a thing as a failed induction. So this is Cervidil, and it is specifically meant to ripen the cervix and get them ready for labor. So one point I'd like to make about induction is that it doesn't happen as fast as labor does. I said in another video that we're asking the woman's body to do what it would do over several weeks' time in a couple of days. So inductions typically are 3 to 4 days long before we even get them into labor. Here are some of those other medications. Oxytocin is the natural hormone that occurs in the body. Pitocin is the synthetic form. We do use Pitocin in the hospital. It is a high alert double check medication because it can cause great harm. In fact, many of the lawsuits surrounding labor and delivery involve the use of Pitocin. Here's the misoprostol that I mentioned. The dinoprostin is your Cervidil, and these are the meds that we use that work on the cervix, work on the uterus, and cause contractions or get it ready for labor. So here is an example of what a med tactus might look like. I'm not saying that you have to do this with every med, but every prudent nurse needs to know at least this information or be able to know where to find this information before giving this medication. So this one happens to be for oxytocin, and here's the purpose of it: induction of labor at term or postpartum to control bleeding. And here's how it works. Here is the contraindication. So things we should know is we use cautiously in first and second stages of labor. Slow infusion over 24 hours has caused water intoxication with seizure, coma, or maternal death due to its antidiuretic effects. So even though this medication is used just about every day in labor and delivery and has been used by every labor and delivery nurse, this information needs to be first and foremost. There is the possibility of severe contraindications and issues with this medication, especially long-term use. Here are some of the side effects. You can have severe hypertension, especially if we're using vasopressors, which can happen. Vasopressors sometimes are used after epidurals to counteract that decrease of blood pressure. So interventions, these are things that we would want to do, and it can occasionally cause water intoxication. So we need to be watching very closely our input and output. And for these signs, anytime a woman is on Pitocin. So my point is, this medication is not benign, and every prudent nurse needs to know at least this minimum information in order to be able to safely give any medication. So here are some starting dosages for your Pitocin, and this information was taken from this MedDeck book in 2014. This is medication, like I said, is one of the number one reasons that number one medications that we see related to our lawsuits in labor and delivery. And so it's become such a high risk use that every patient, before we start this medication, we must complete this pre-use checklist. And every 30 minutes that we are on this medication, we're going to be documenting all of these criteria. So using Pitocin is not benign and needs to be taken very seriously. And if we can avoid it, then we should, and let the woman's body do things naturally on her own. Mechanical induction is where we are actually using a tool to mechanically stretch that cervix out. This one is called a Cook's balloon, and it's a lot like a Foley. It's placed by a provider, either a midwife or a physician, and then these balloons are filled up with water. It will put manual pressure on the cervix, and then when the cervix is about 4 centimeters dilated, it will fall out on its own. So that's called a mechanical induction. And then another intervention that we potentially can use is called an amnioinfusion. An amnioinfusion is where we use an internal pressure monitor, IUPC, internal pressure catheter, that is placed by a physician or a midwife. And then we can use this to attach fluid to it and put fluid back in for specific reasons. So some of the reasons we might do this is if there's very thick meconium, we might want to thin it out just a little bit so that it decreases the chance of the baby taking a big deep breath of it. Or if there's too little fluid and it's causing variable decelerations in our fetal heart rate monitor, we can put some fluid back in and decrease the compression on that cord. So this is something that we would monitor. And again, it's going to depend on your facility, but in our facilities, we never put this on a pump. This is free flow to gravity, and we need to be paying very close attention about the fluid coming back out, because if we're putting fluid in, we need to see fluid come back out. If we continue pumping it in and this baby is blocking it from coming back out, we could actually cause a uterine rupture. So we need to be very careful about watching for those for the fluid to come back out. So that's an important assessment. The other monitor that we can use here is called a fetal scalp electrode. This is called an internal fetal heart rate monitor, and it is placed just directly under the baby's skin, and that will give us a very good indication of the baby's actual heart rate rather than the estimate that we're getting from the external monitor. I don't see internal monitors used as much as I used to. We know that they greatly increase the chance of infection, and so we are try to avoid the use of them unless it's specifically necessary. When I am discussing operative vaginal delivery, I'm talking about either forceps or vacuum. These are both done by a provider. And the reasons that we would use an operative vaginal delivery is that we are very close to delivery and the mom is having either a prolonged second stage, or we have non-reassuring fetal heart tones, and the physician or midwife feels like they can bring this baby out faster this direction by using an operative vaginal delivery. Sometimes the presenting part is not fully rotated and they could use a vacuum to help that happen. If the mom is unable to push due to a very heavy epidural or some other condition, that would be a reason for it. Maternal heart disease, where it would be detrimental for her to bear down and push. Sometimes infection, maternal fatigue. These are all reasons that this might be chosen. Informed consent needs to happen before any of these are done, and there's a risk of tissue trauma to both mother and baby. The next picture is an example. This is a vacuum that is used, and there will be certain protocols in every facility about how long the vacuum can be on, usually no more than 20 minutes, how many times it can pop off and be put back on, usually no more than 2, and if we do not get the baby out using this tool, then we have to move to our exit strategy, which would be going to an emergency cesarean. So it would be prudent to have the consent signed, to have informed consent that if this doesn't work, we're moving to cesarean before we even start the process. So this picture is of a vacuum, and this picture is of forceps. We don't see forceps used as much anymore, but there are some doctors, older physicians, that were trained in the use of forceps that can do them very gently. And then last but not least, our intervention could be cesarean birth. There are lots of reasons for cesarean, medical indications, and we live in a wonderful time where if we do have a cesarean, we have the ability to have both mom and baby survive it. There was a time when we were actually choosing between mom and baby when we chose a cesarean. Nowadays, so our cesarean is the most commonly performed surgery on women. And in the last 30 years, we've seen about a 60% increase in our cesarean section rate. So let's talk about this for just a minute. Here we are in the United, you can see the whole world actually, and you can see the places that have the lowest cesarean rate and the places that have the highest cesarean rate. And many places were well over 30%, and in some places we're even higher than that. In the places in Brazil, there's more than 60% of women are having cesarean sections. So when cesareans became more popular, the onset of antibiotics, the ability to have a cesarean under spinal anesthesia, and the woman can remain awake and still be part of that process, there was the idea that we had an increase in these, there was an increase in the cesarean sections because we were saving more babies. The idea that cerebral palsy and neonatal seizures could be decreased with greater use of cesarean was very widespread. In fact, it still remains today. But the fact is, since 1980, our cerebral palsy rates and neonatal seizure rates have remained unchanged despite the huge increase in cesarean sections that we've seen. So what that tells us is more cesareans do not equal healthier babies, and they do not equal healthier mothers. And so why should we be concerned about the cesarean section rate? Why is this such an issue? It's become kind of a benign surgery. We have a overall view in the medical community that it's just no big deal. In fact, if you look at throughout the United States, there are some places that are higher than 36%. Look at some of these states. And it is different throughout our geographical region. So what this means is the women throughout the United States, if we're all living similar lives, then we should have a similar amount of cesarean sections needed for the health of the population. But you can see by these great differences in the amounts of cesareans that are given that that's not the case. Looking at the reasons for cesarean section, I want you to pay very close attention to this slide. Here, 23% of our cesareans are done for non-reassuring fetal tracings. These are babies we're concerned that are not getting enough oxygen. Only 23% of our C-sections are done for that. Another 7% are done because of multiple gestation. Another 3% are done because of preeclampsia. Look at this one. Excuse me. 34% of our C-sections are done for labor arrest, meaning labor that didn't continue, labor that wouldn't finish to the end. 17% are done because of fetal malposition. So what is that saying? We're doing a whole lot of C-sections for these two reasons, and a good labor nurse and appropriate medical care and women making informed choices will decrease the amount of those types of C-sections. Okay, so good labor management will decrease the C-sections that we're doing for those two reasons. Look at this one. 3% of the C-sections that we're doing are from maternal request. This is not a repeat C-section. This is a primary C-section. This is the first one. So some women have bought into the idea that a C-section is much easier or just as easy as having a vaginal delivery. And unfortunately, there are some very big risks associated with cesarean. Now, don't get me wrong. I'm happy that we have them. I'm thrilled that I live in a time when both mom and baby can survive. But when we are looking at this attitude that we have a casual acceptance of cesarean birth as safe and easy, we are giving women an unrealistic view. Our bodies were made to birth babies, and if at all possible, we should be attempting to do it vaginally. Now, obviously, there are some reasons that that cannot happen, but there are some specific risks associated. Here we are looking at the acute risk. First of all, it's a longer hospital stay. Longer hospital stay means it costs more. There's increased pain and fatigue. Women don't bounce back after cesareans like they do from vaginal deliveries. Slower return to activity and productivity. Sometimes there's delayed or difficult breastfeeding. There's a greater risk for a postpartum hemorrhage after a cesarean section. There's anesthesia complications. There's wound infection, and there's a greater risk for a deep vein thrombosis. Long term, what we're seeing is with each subsequent pregnancy, she's now at higher risk for all of these things. Abnormal placenta implantation. This is where we see increased previas or accretas, where it grows into the uterine tissue. They have an increased risk for uterine rupture. There are surgical adhesions that happen. There's surgical injury that happens to the bladder or bowel. And then there's an increased risk of bowel obstruction. So cesarean sections are not benign. There are increased risks to our neonates. We're seeing increased risk for respiratory function. Babies have increased NICU admissions when they're born through cesarean because they don't get that same squeeze that helps them get all that fluid out and helps them start to push the fluid out and breathe normally. And then this will interfere with the maternal newborn interactions, which will affect breastfeeding if we don't get to breastfeeding right away. So having said all of that, I recognize cesarean births are life-saving and they have an absolute role in obstetrics. So what we're trying to say with all this information is they shouldn't be taken lightly. And if we can avoid them, we should. And if we as nurses have the ability to make a difference in the amount of cesarean sections that are being performed, we should do that. So the next pictures are of some cesarean births, and we need to remember this is still her birth. This is the birth of her baby, whether she wanted to be in this position or not. This is one of the most momentous days of her life. There's kind of a trend right now of having this plastic sheet available for women to be able to see through and see the birth of their baby. These aren't being used in our local geographic area, but they are being used in some other places. And then getting that baby up close to that mom, allowing them to snuggle, allowing them to spend skin to skin time. Nurses can really make a difference in this area. Letting them spend uninterrupted time afterwards, very, very important. So here's a little story for you. Both Sarah and Maya are expecting their first child. They have low-risk pregnancies. How different can their birth experiences be? Well, what this infographic is really talking about is it really comes down to the doors that you walk through in order to receive your care. If you go to a hospital that is a low-performing hospital, you may increase your chance of a cesarean section 50, 60% just by the doors that you walk through. But if you go to a hospital that is a high-performing hospital, we see some that have cesarean section rates as low as 19%, which really across the world and across the United States, if we're under 23%, they're happy. The World Health Organization says we should be more about 15% for the population. So the easiest way to find out if you're at risk for having a C-section based on just the place that you plan to deliver, go online. You can go on Health Grades. You can go on this website, calhospitalcompare.org, and it will let you know exactly what your hospital's doing as far as their C-section rates. Insurance companies are looking at this. Patients are taking a more active role. Certain providers that have really high cesarean section rates that are unnecessary are being asked to change their practices and start encouraging vaginal birth. When we are caring for a woman that has had or is going to have a C-section, we're talking about her pre-op care, her intra-op care, and her post-op care. So we have different criteria for each of these things. So now it's not just a mother and baby. It has become a surgical patient as well. Here is an actual picture of a baby being born through that incision. In some geographical areas, they'll call in an OR team to circulate, but in many labor and deliveries, the labor and delivery nurse will also be a circulating nurse in the operating room. We have different roles and responsibilities when we're in the operating room, and I will cover that in another video. Here are two different types of incisions that are being made. This one is what we call the classical or vertical. This one is not a good candidate for having a vaginal birth afterwards. This is the low transverse incision, and this one does put the patient at being a better candidate for having a vaginal birth in her subsequent pregnancies because of the way the tissue heals. There are several different methods of closing up those incisions. Some use glue and steri-strips, some will use stitches, and some will use staples. That depends on the provider. Good question for our patients to be asking. And then vaginal birth after cesarean, there's a lot of controversy related to the risk of uterine rupture. There are some contraindications to having a vaginal birth after cesarean. Nurses really need to be working and acting as advocates for these patients, and they need to have expertise in reading that fetal monitor and looking for the non-reassuring fetal heart tones. And we have seen kind of the pendulum go back and forth in vaginal birth after cesarean, and women that are wanting them and women that aren't wanting them, and providers that are willing to do this for a patient. They have to be in-house. There has to be emergency care in-house in order for a patient to be laboring on a uterus that has already had a previous incision. But we need to give patients good information and direct them to the providers that will give them accurate information so that they can make informed choices about these decisions. This is a really great article about 13 myths about vaginal birth after cesarean. I'll let you read that. It is pretty recent. Actually, 2014 is when this came out. So there's some good information available. And then the next couple of slides, the last thing I want to talk about is our intrauterine fetal demise. This is a part of our labor and birth that we don't spend a lot of time talking about as nurses, but this is one of the potential issues. There are numerous causes for babies that die, perish before they're born. We don't always know. Sometimes there's cord accidents, sometimes there's anomalies, sometimes it's placental abruption, like we mentioned, placenta previa. We don't always know. But as the nurse, if we are unable to obtain fetal heart tones, once we are putting a patient on the monitor, she comes in for decreased fetal movement, then we need to stop, go and get a provider, let them know our suspicions, and get an ultrasound in there, because spending a lot of time trying to find heart tones just increases the anxiety of the patient. And then once it's been determined that the baby has passed, we are going to now look at an induction and delivery. Once the delivery has happened, it will be up to us to help with collecting keepsakes. Many facilities have memory boxes. We do photos. Sometimes social services is involved with this, chaplain, if possible. Most hospitals have either purchase items or have items donated to them that will be given to the families as keepsakes. Of course, we want to encourage these moms to get some counseling, grief counseling, and support for next pregnancies. So if you're taking care of a mom that's had a history of this, obviously she's going to be very fragile. Pictures are very popular. These are the only pictures that they will be able to go to have with this baby, and we need to support them. In our area, we have a group that will take donated wedding dresses and gowns and make these specific gowns for these babies, and I know they are highly treasured for highly treasured keepsakes. Okay, I'm going to leave on that note. And if you have any comments or concerns, you're welcome to reach out to me. And I hope you've enjoyed this video.